Welcome to the Everything Surgery podcast. Today we summarize the American Society of Colon and Rectal Surgeons clinical practice guidelines for the treatment of left-sided colonic diverticulitis, ASCRS mission, advancing the science, prevention, and management of disorders and diseases of the colon, rectum, and anus to ensure high-quality patient care. Guidelines Committee, composed of experts in colon and rectal surgery, tasked with defining quality care and developing evidence-based clinical practice guidelines. Guidelines purpose: provide information to guide decisions about managing colon, rectum, and anus conditions, but do not dictate specific treatments. Methodology: search strategy. A systematic search of PubMed, Embase, Cochrane, and Web of Science databases was conducted from January 1, 2013, to October 26, 2019. Using specific keywords related to diverticulitis and its treatment. Inclusion criteria: the search was limited to English language abstracts with human subjects. Prioritizing prospective trials, meta-analyses, systematic reviews, and practice guidelines. Exclusion criteria: case reports, letters to the editor, non-systematic reviews, and studies with insufficient evidence were excluded. Guideline development process: the guideline was developed by a subcommittee, reviewed by the entire committee, and peer-reviewed by an external journal. Evidence evaluation and recommendations: the evidence base was examined using the grade system, and recommendations were formulated based on the strength of evidence. Terminology definition: the guideline defines terms like uncomplicated diverticulitis, complicated diverticulitis, and symptomatic uncomplicated diverticular disease, SUD. Recurrent diverticulitis definition: no universally accepted definition, varying across studies. Clinically overt colitis, mentioned in the context of recurrent diverticulitis but not further defined. Statement of the problem: prevalence increase. The prevalence of diverticular disease has risen steadily in industrialized nations over the past few decades. Hospitalization rate: hospitalization for diverticulitis increased from 74.1 per 100,000 in 2000 to a peak of 96.0 per 100,000 in 2008. Ambulatory setting diagnosis: in 2014, there were 1.92 million patients diagnosed with diverticular disease in the ambulatory setting. Diverticulitis emergency department visits increased by 26.8% from 2006 to 2013. Costing $1.6 billion in 2013. Hospital admission rates for diverticulitis decreased from 58.0% in 2006 to 47.1% in 2013. Emergency bowel surgery for diverticulitis decreased from 7,278 to 4,827 per 100,000 emergency department visits between 2006 and 2013. Initial evaluation of acute diverticulitis 1. The initial evaluation of a patient with suspected acute diverticulitis should include a problem-specific history and physical examination and appropriate laboratory evaluation. Grade of recommendation: strong recommendation based on low-quality evidence. 1C2. CT scan of the abdomen and pelvis is the most appropriate initial imaging modality in the assessment of suspected diverticulitis. Grade of recommendation: strong recommendation based on moderate quality evidence. 1B3. Ultrasound and MRI can be useful alternatives in the initial evaluation of a patient with suspected acute diverticulitis when CT imaging is not available or is contraindicated. Grade of recommendation: strong recommendation based on low-quality evidence. 1C. Medical management of acute diverticulitis 1. Selected patients with uncomplicated diverticulitis can be treated without antibiotics. Grade of recommendation: strong recommendation based on high-quality evidence. 1A2. Non-operative treatment of diverticulitis may include antibiotics. Grade of recommendation: strong recommendation based on low-quality evidence. 1C3. Image-guided percutaneous drainage is usually recommended for stable patients with abscesses, 3 cm in size. Grade of recommendation: strong recommendation based on moderate quality evidence. 1B4. Tobacco cessation, reduced meat intake, physical activity and weight loss are recommended interventions to potentially reduce the risk of diverticulitis. Grade of recommendation: strong recommendation based on low-quality evidence. 1C5. Mesalamine, rifaximin, and probiotics are not typically recommended to reduce the risk of diverticulitis recurrence but may be effective in reducing chronic symptoms. Grade of recommendation. Weak recommendation based on moderate quality evidence. 2b. Evaluation after recovery from acute diverticulitis. 1. After resolution of an episode of acute complicated diverticulitis, the colon should typically be endoscopically evaluated to confirm the diagnosis if a colonoscopy has not been performed recently. Grade of recommendation. Strong recommendation based on low-quality evidence. 1c. Elective surgery for acute diverticulitis. 1. After successful non-operative treatment of a diverticular abscess, elective resection should typically be considered. Grade of recommendation. Strong recommendation based on moderate quality evidence. 1b2. Elective colectomy should typically be recommended for patients with diverticulitis complicated by fistula, obstruction, or stricture. Grade of recommendation. Strong recommendation based on moderate quality evidence. 1b3. Elective resection based on young age at presentation is not recommended. Grade of recommendation. Strong recommendation based on low quality evidence. 1c4. The decision to recommend elective sigmoid colectomy after recovery from uncomplicated acute diverticulitis should be individualized. Grade of recommendation. Strong recommendation based on moderate quality evidence. 1b5. The decision to offer sigmoid colectomy after recovery from uncomplicated acute diverticulitis in immunosuppressed patients should be individualized. Grade of recommendation. Strong recommendation based on low quality evidence. 1c. Emergency surgery for acute diverticulitis. 1. Urgent sigmoid colectomy is typically advised for patients with diffuse peritonitis or for those in whom non-operative management of acute diverticulitis fails. Grade of recommendation. Strong recommendation based on low-quality evidence. 1c2. Following resection, the decision to restore bowel continuity should incorporate patient factors, intraoperative factors, and surgeon preference. Grade of recommendation. Strong recommendation based on moderate quality evidence. 1b. Laparoscopic lavage. 1. Laparoscopic lavage is not recommended in patients with feculent peritonitis. Rather, colectomy should typically be performed in this situation. Grade of recommendation. Strong recommendation based on high-quality evidence. 1a2. In patients with purulent peritonitis, colectomy is preferred over laparoscopic lavage. Laparoscopic lavage is associated with higher rates of secondary intervention in comparison with colectomy. Grade of strong recommendation based on high-quality evidence. 1a. Technical considerations. 1. The extent of elective resection should include the entire sigmoid colon with margins of healthy colon and rectum. Grade of recommendation. Strong recommendation based on low-quality evidence. 1c2. When expertise is available, a minimally invasive approach to colectomy for diverticulitis is preferred. Grade of recommendation. Strong recommendation based on high-quality evidence. 1a. That's it. If you enjoy our content, please like, share, and subscribe to the channel. It's the Everything Surgery Podcast. Dissect the extraordinary.